Hi and good morning, everyone. My name is Ray Dizon. I am the project coordinator for the National Consortium of Telehealth Resource Centers. I'll be moderating today's session. Thank you again for joining us for today's session. It's going to be on lessons for sustainability from the Massachusetts Health Policy Commission's Telemedicine Pilot Initiative. A few things before we get started. So your audio and your video have been disabled, so attendees will not be able to use their audio or their video. And we do advise that attendees please use the EventMobi app to submit your questions. We'll be going over the Q&A towards the end of the presentation. And at this point, I'd like to introduce our presenter, Catherine McLean, and I'll pass it on to you.
Thank you so much, Ray. Good morning, everyone. I want to thank you for taking the time to attend today's presentation. So I am a program associate at the Massachusetts Health Policy Commission, working on our healthcare transformation and innovation team, and my work focuses on evaluation of our investment programs. And so today we are going to talk a little bit about sustainability, what we learned from our telemedicine pilot initiatives, and hopefully some great takeaways for you on sustainability of telehealth programs. So just to begin, I have nothing to disclose, but I do want to just take a minute to thank my colleagues, Fran Hodgkins, Jonathan Walensky, and Courtney Wright, who supported the telemedicine pilot program and its evaluation. So just to start, run through our agenda really quick. I have some objectives to share. We'll do a little bit of background on the Health Policy Commission and our telemedicine pilot initiative. We'll spend a little bit of time sort of pulling back to ask what is sustainability, and then dive into what our initiatives sort of experienced with sustainability and some lessons learned and takeaways. So our objectives for this morning: attendees will be able to list different means of sustaining a telehealth program. Attendees will be able to describe key considerations when seeking to sustain a telehealth program, and attendees will be able to appraise options for sustaining a telehealth program within their organization. To start with a little bit of background, the Massachusetts Health Policy Commission is an independent state agency that was established by the landmark healthcare cost containment law that the state of Massachusetts passed in 2012, called Chapter 224, an act improving the quality of healthcare and reducing costs through increased transparency, efficiency, and innovation. So a good portion of the work that our agency does is focused on the healthcare cost growth benchmark that was set by this law for the state of Massachusetts. But we also have sort of a broader mission and vision that is focused on a transparent and innovative healthcare system that is accountable for producing better health and better care at lower costs for all the people of the Commonwealth. So one way that we sort of realize that vision is through our investment programs that are used to test and spread healthcare innovations. We were given the general authority to administer such programs by Chapter 224, and in some cases we are given, very specific instructions for certain investment programs, and all of our investment programs really focus on investing in provider organizations, health systems and their partners, and advancing new models of care, advancing new ways of care delivery, and we really put a lot of emphasis on local care and community partnerships through these programs. So a major investment program of the HPC was the Healthcare Innovation Investment Program. This was an $11.3 million investment in innovative projects, again, furthering that goal of better health and better care. The Healthcare Innovation Investment Program contained 3 different pathways, and today we're going to be specifically focusing on our telemedicine pilots, which took place between 2017 and 2018. So this program was very specifically directed by the legislature. We were in 2015 given a direction to implement a one-year regional pilot program to further the development and utilization of telemedicine in the Commonwealth. The legislature, I think, realized that there was a lot of interest around telemedicine, but the landscape was still emerging, and there was an opportunity with this program to kind of test the waters, learn a little more about what telemedicine could look like and what it could do for patients in the Commonwealth. We were further asked to take into account the previously established geographic regions. So the HPC, for those who are, maybe not as familiar with the Massachusetts healthcare landscape, we have a lot of healthcare resources, a lot of academic medical centers, but they are not distributed evenly from a geographic standpoint. And so, that's part of the interest in telehealth, is the ability to take resources that are sort of in one part of the state and bring them through telemedicine to areas that maybe don't have as many providers as they need, where there are needs to be filled for patients. And so the HPC uses these geographic regions to ensure investments are reaching areas of need in the Commonwealth and are spread among different communities. There was also a directive to incentivize the use of community-based providers and delivery of care in a community setting, and then facilitating collaboration between participating community providers and teaching hospitals. So again, we're trying to move care sort of more into the community where patients are. So after very careful consideration about what type of telemedicine would be most effective to deploy, which included, stakeholder engagement and getting feedback, the HPC rolled out our telemedicine pilot program, which was designed to increase access to behavioral health care for children and teens, older adults aging in place, and individuals with substance use disorders. So these were 3 target populations where, behavioral health care shortages were known, and where the HPC decided to put the priority in this telemedicine program. The awards could be up to $500,000, with a total of $1.7 million available for the whole program. And the request for proposals was put out by the HPC in March 2016. After evaluating 11 proposals, 4 initiatives were chosen to be funded by the HPC, with 21 different organizations involved in the program through partnership. So there were 4 awardees, but each of those awardees collaborated with a number of partners. And as you can see from this little map of sort of where the different partner organizations were located, we really did have the opportunity to spread this initiative throughout the state. This is a very brief run through of the 4 funded programs. As you can see, we've color coded. So Haywood Hospital and the Pediatric Physicians Organization at Children's, we're serving children and adolescents. Haywood doing a school-based telemedicine program for adolescents, and the Pediatric Physicians Organization, or PPOC, doing a pediatrician's office-based telemedicine program. Riverside Community Care is serving older adults aging in place, and UMass Memorial Medical Center is working in the hospital for patients with substance use disorder. To give a little bit more detail on each of these programs, Haywood provided behavioral health therapy sessions to students in the school building during the school day. So they would be, taken from sort of their elective classes as opposed to their academic classes or their study period. And there was a space within the school where they could have a telemedicine meeting with a therapist from Clinical and Support Options, which was rather distant. In this area, the availability of behavioral health services for youth is a challenge, and so they brought the sessions, to the students in the schools, which also helps, reduce transportation barriers and other access barriers. We're meeting the students where they already are. And you can see some details here about the funding and the duration of their program. They also created a position called a school-based care coordinator who helped facilitate these telehealth sessions and also provided other supports to the students and families in the school. So Riverside, again, this is working with older adults aging in place, very specifically homebound elders who they worked with local aging services access points or ASAPs to identify patients who might benefit from these behavioral health services. And then they had case managers actually bring the technology to the patients in their homes to facilitate the telehealth sessions. UMass Memorial Medical Center has two campuses, Memorial and University, and the Memorial campus at the time of this program did not have full substance use disorder services, though they did treat and see a number of patients with substance use disorder. So they were able to, through this program, bring some in-person staff to the campus through our funding, but also what they were able to do is there was an addiction psychiatrist who worked on the university campus, and they were able to use the telemedicine link to bring that physician to the bedside of patients while they were inpatient, possibly for substance use disorder or other related or unrelated conditions. But they were really able to take the opportunity of the hospitalization to get to know the patient, to engage them in the possibility of SUD treatment services. And the peer recovery coaches who made sort of first contact with most of the patients were also the ones who helped facilitate those telemedicine sessions. And they also had the support of an addiction social worker. So again, PPOC, this is the Pediatric Physicians Organization at Children's Hospital Boston. So this is Boston Children's Hospital's Physicians Organization. They have a number of pediatric primary care offices that are located throughout the state. And so they have a strong and close affiliation with Children's Hospital Boston and the Department of Psychiatry at Children's Hospital Boston. And so they were able to use the telemedicine link to bring one of the child psychologists from that, psychiatrist from that department into the pediatrician's office. And if you take a look at their list of partners over here, the pediatrics office is located in places like Sandwich, Yarmouthport, Lowell, Holyoke, Northampton. For those who maybe do or don't know their Massachusetts geography a little bit, all of those are rather distant locations. Massachusetts is a small state, but you know, even the distances that we're talking about here would be a two hour and more drives potentially to get to Boston. And so this removed that barrier for patients to get psychiatric consult services, and also enabled co-management of many of these patients between their pediatrician and the psychiatrist. So now that you've heard a little bit about our programs, I want to shift our focus for a moment to the broad concept of sustainability. And I want to start really just by saying that and acknowledging that sustainability is challenging. This is not easy stuff. This recent publication in the Annual Review of Public Health highlights that sustainability is an area in need of much more research. I think implementation science has come a long way, and the keys to putting a program in place successfully have been very well studied. But how to keep a program going long term has gotten a little bit less attention, which contributes to a lot of challenges in sustaining innovative programs for healthcare delivery. One way to respond to these challenges is to create a very clear and practical definition of sustainability. I think a lot of times we can get a rather narrow or somewhat idealized conception of sustainability in our heads, and it's this sort of perfect case of the program generating so much revenue or so much savings that it's just self-funding, covers all the cost, and this happens, during the program period with almost no effort. And so you can just keep going on your merry way when, either initial funding that was put into the program or, the initial trial period that was agreed on by your organization kind of comes to its end. But I think we all realize that that is an extremely rare, possibly non-existent case. The same paper that I referenced in the previous slide from the Annual Review of Public Health from Shelton et al. Gives us a slightly different definition of sustainability that can be applied a little more readily to real-world conditions, which is the continued use of program components at sufficient intensity for the sustained achievement of desirable program goals and population outcomes. So what does that, sort of look like in practice? We're going to apply the architecture of that definition from Shelton et al. And put it in more everyday language, sort of starting with a question to be asked about the program. What has to be sustained to achieve desirable program results? And then a series of points to form an answer. So first, I think you really want to drill down to the program results. What impact are you having on the target population? What goals did you set when you began the program, and what are the outcomes that you can see that tell you that you are achieving some of those goals? And then what are your key program components? What is most directly creating the impacts on the patients or the participants that you're serving in the program? And then what level of those components might be necessary to continue most or all of that impact? Then I think it's important to think about, are there additional features, other program components that have added value or are increasing the impact that sort of surround your main interventions, but nevertheless you found are really important to it? And then what is the necessary support that has to be in place to allow all of those program components to continue functioning? And I think, the first place that generally we tend to go when we're thinking about support for a program is the financial aspect, which, we're not here to pretend that that is not important. But I do think it's important to step back and consider that support has many dimensions. There are other factors really that do play into program sustainability. So this includes things like quality and mission alignment. If the program that you are operating is not aligned with the organization's mission, is not producing better quality care, it's going to be really hard to make the case to be sustaining that program. The participants, do they enjoy the program and find that it fills a need? Does that need still, exist? Without participants, it's pretty hard to keep a program going. Has leadership been kept up to date on the impact of the program, the value that it's created, what kind of experience it's created for the participants and for the staff involved? I think that buy-in, having the leadership of your organization understand the program and why it's important. And then, as we said, financial support is important, and we're going to talk about that a little more, in particular covering program staffing, because I think, having staff, oftentimes you bring people on to be part of a program, and they really become the heart and soul of that program. And, with short-term efforts, it can sometimes be hard to keep those really wonderful staff members as part of the team. And then, is the staffing model that you have set up working for the initiative? Is it serving all of the needs it should? And then are you running into any workforce challenges with keeping the program going or even potentially scaling it? Finally, has the program, created culture change? Are the staff who might refer to your program or interact with your program bought in? Do they understand the value of the program? Because I think that can also be a really key domain for generating support. You can potentially even generate champions for the program out of getting that kind of buy-in. And I think, the way in which new programs, new methods of care delivery can really change culture is sometimes an underrated note to make about how programs can have an even more lasting impact. To spend a little bit of time on financial sustainability, because again, this is important. This is often the area that is of most challenge for programs, is figuring out, the things that we are doing cost money. Where is the money coming from? So I think, sometimes, again, too, we can define these things too narrowly, and I really want to just encourage sort of being really broad about what you consider. These are 4 very general categories, but there's a lot to dive into in each of them. So we're all obviously familiar with the concept that programs can generate revenue. I think it's important to be sort of eyes wide open when you're heading into a new endeavor about what the prospects are on generating revenue. The pilots that, the telemedicine pilots that the HPC funded, the real intention was, this is a new area for Massachusetts, or a newer area for Massachusetts. We don't yet have all insurers providing reimbursement for it. And there are not super clear avenues of getting reimbursement from all insurers. That wasn't necessarily on the horizon. And so being clear that is it likely to generate revenue? Sometimes yes, but sometimes you're sort of ahead of the curve, and that was the case. These telemedicine pilots really were ahead of the curve in a new, they were piloting. And so I think that's important to think about. Similarly, in terms of generating savings, there are options, in the context either of risk sharing or in decreases in care utilization for a program to generate savings. I think here again, it's also important to go in sort of eyes wide open about likelihood. In the case of these telemedicine pilots, we were for the most part introducing a new care, and the goal was really around increasing access to care. And so while there might be some downstream effects on utilization from that, in general, if you're providing care sort of where there wasn't before, you have to think about what are the savings prospects there. And I think, this, similarly in terms of the landscape, this was also a time where ACO growth in Massachusetts was not as robust as might have been expected. So that's another place that I think people think about, shared savings or risk, or even potentially, you could think about generating revenue through programmer per month arrangements. That wasn't, again, you have to be sort of realistic. Those are options, but sort of understand what the landscape is, what the prospects are. And then finally, thinking about alternative outside funding sources and repurposing existing budgets. These are sort of the less commonly thought about. I think they're thought of as sort of less ideal, and they do pose challenges in terms of, alternative outside funding sources are often grants that are term limited, and that's really challenging because you can feel like you're sort of on this treadmill of just trying to get grant funding. But I also think there can be a lot of opportunity in that to generate the kind of data or refine the care model so that you do have better prospects for other means of financially sustaining the program. So there can really be an opportunity either because the grant requires you to have a sustainability plan, or because you can use that additional time for the program to really hone in on that. And then repurposing existing budgets, the challenge being, we all know, nobody has a lot of extra budget lying around. Budgets are tight everywhere. But I think this is an opportunity maybe to go back to some of those earlier points that we were talking about and say, what is the intensity of services needed to create the impact that we want to in the target population. So are there opportunities to scale so that repurposing existing budgets or rolling team members into a new team and sort of diversifying their roles has the opportunity to kind of create that as a viable option? And then are there opportunities to combine some of these strategies? So I think, there's a lot to consider here, but I think having as many options sort of on your mind is an important thing to be thinking about. Another key factor to consider is, despite the cautions I just gave you about being realistic about payment, it is also true that payment landscapes can shift, and sometimes rapidly. As you see here, just after the last of our pilots ended in 2018, there was a change in Mass Health, which is our Medicaid program, that changed how they reimbursed for, or introduced the option of reimbursement for telebehavioral health for those patients. We have also, all of us in the last few months, seen rapid changes at the state and federal level in terms of payment policy or around telemedicine due to COVID-19. It obviously remains entirely unclear whether any of those policy changes will become permanent. But I know our state legislature has some bills under consideration that would expand reimbursement. So I think, as much as, you have to be realistic, it is also true that your sustainability plan may need to adjust to changing tides, and that, just because something isn't reimbursable now doesn't necessarily mean, that can change. So now I want to share a little bit of a framework that we're gonna use to consider sustainability that is organized around the principles we laid out and the factors for sustainability that I discussed. And then I'm going to talk through applying it to our 4 pilots so you can get a sense of their varied experience. So here we're considering, the question of what components are most important, and then also what factors for sustainability are sort of already present. Considering other components of the program and maybe areas that need a little work in terms of your factors for sustainability. And then, what actions can be taken and what outcomes are you realizing in terms of sustainability for a program. So to start, Haywood Hospital, just to jog your memory, was our program bringing telebehavioral health sessions to middle and high school students in their schools. And they really felt like the telebehavioral health sessions and having the sessions facilitated by the school-based care coordinators was really important. The school-based care coordinators were able to make sure students attended their appointments, check in with them afterwards if they had discussed something particularly difficult or emotional, and help them have a cool down period before they went back to class. Scheduling was often challenging. They only had one clinician, so shuffling schedules around was often necessary. Kids are out sick from school, all of these sorts of things. They had a lot of leadership and staff buy-in, really largely thanks to the fact that the staff at the schools were able to observe a change in students' performance and behavior. They really felt like the sessions were benefiting the students and helping them, engage better in school. The students also really liked the sessions. Teenagers famously pretty comfortable with technology, and so a lot of them found it really easy to have therapy sessions via telemedicine, and they liked the opportunity to have somebody to talk to and process the things that they were going through. Obviously, schools are really focused on, whole child, whole adolescent wellness, and this was a way to realize that mission. And Haywood Hospital, it's also really focused on community wellness. So they had all of that in alignment. The components that really added to their program was, in addition to their sort of session facilitation work, the school-based care coordinators provided almost community health worker type services in terms of connecting students to internship and job applications, helping their families with utilities assistance, applying for food assistance, other, areas that they might need help in. They were able to be involved in community meetings about adolescent mental health. And so they really felt like having that role was essential. As I mentioned, they only had one clinician, and it was a little bit of a challenge for them genuinely to find counselors who felt, and therapists and mental health professionals who felt comfortable both working with adolescents and working in a telemedicine modality that was new for a lot of the clinicians. And then, of course, financial support was an area where they also had a little bit of a challenge. So they were able to find a larger federal grant, a HRSA grant, the Health Resources and Services Administration, to continue the program. And they also, the program manager from this initiative, spent time advocating to educational institutions that train behavioral health providers and really encouraging them to teach telehealth models so that new graduates coming out of these programs have a comfort and a facility. Again, I think this was 2017 to 2018. I think many behavioral health providers who didn't ever imagine themselves practicing in telemedicine have gotten a little bit of a crash course in the last 3 or 4 months. So it may be that the landscape has changed on this, but I think at the time they felt a really important, avenue to advocate for this training. And Haywood Hospital's program actually presented at an earlier session of this conference, and were able to share that they have delivered over 3,000 sessions to students, and were also able to pivot pretty seamlessly to having the students receive these sessions at home when school went remote this year. And so they have continued the essential program components and those that added value to continue having impact on these students. So moving on to Riverside, which was our in-home sessions for older homebound adults. They really felt like the most important thing was these behavioral health sessions. The participants really benefited from them. Many who had screened positive for depression on the PHQ-9 at the beginning of receiving their sessions, at the end, reported improvements in their symptoms. They got a lot of positive feedback of just that it was nice to have somebody to talk to. Many of these folks were, experiencing grief and loss in their personal lives, and the added challenge of being homebound meant that, they didn't have a lot of people in their lives to talk to. Riverside Community Care being a behavioral health community provider, obviously this was right on board with their mission. And, the staff really felt like this was an important service to be providing, as did the leadership. Facilitating the telehealth sessions was important, but also created a little bit of challenge in that, the case managers had to physically travel to each participant's home and then spend the duration of the session, not in the room, either in the house or outside, depending on the participant's comfort, but spend the duration there so that they could be available to troubleshoot and so that they could collect the technology. And as it turned out, I think, the participants, many of them didn't need quite as much technological support as maybe had initially been anticipated by Riverside. So the staff sometimes felt like, they were constrained by the number of sessions that could be done in the day, and they were often just sort of waiting. And so that, posed a little bit of a challenge for the program. And then obviously financial support, another challenge here. And so Riverside did end up discontinuing the program at the end of the performance period with HPC funding. Though, we did get an update from them that they did later start offering some other services. So once that policy change in Massachusetts that allowed mass health reimbursement came in 2019, later on in 2019, they started offering some of the other behavioral health services that they offer as an organization via telemedicine. And they did credit some of the experience and the learnings that they generated from participating in this pilot with their ability to, sort of remount some telemedicine-based services, though not this care model. So I think it's, important to consider that sometimes the learning is what stays with you, even when the program ends. And so, though they didn't sort of sustain in our understanding of it, there was learning that was generated and valuable to them. So UMass was our program bringing substance use disorder treatment to inpatients on one campus, sort of from the other via the telemedicine link and via some in-person supports. So they really narrowed in on the SUD treatment services being the most important part of this program. That was a real lack that was felt very acutely on the Memorial campus, is that they'd see these patients and really not have a lot to offer them other than, a list of suggested places to follow up for treatment once they were discharged. And they really wanted to, use the time that patients were inpatient to see if they were interested in this kind of treatment and engage them. And so filling that need created a huge amount of buy-in from the leadership, from the referring staff, from the staff who were taking care of these patients while they were inpatient. Participants also appreciated being able to have those conversations, having peer recovery coaches there sort of while they were inpatient. Obviously, providing higher quality care, always the goal. So there was a real mission alignment here. And I think also the team on the UMass program very carefully focused in on collecting data about readmissions, because there was a big hospital-wide push to improve their 30-day readmission rates. So they collected data that showed that patients who were touched by this program had improved readmission rates, lower readmission rates. And they were also able to find that the dual eligible Medicare, Medicaid patients who were covered by the medical center's ACO were sort of disproportionately served and really in need of these services that this program offered in terms of access to SUD treatment. And so they were able to, have that data to really push, we are aligning with the larger goals of the hospital here. And that, enabled them to, despite the fact that they did not have a ton of financial support and that they felt the peer recovery coaches were really essential, but that's not the type of service that can be, reimbursed. They were able to go to hospital leadership and secure funding for the program, though at a reduced capacity. So half staffing, half capacity. So they were able to continue this inpatient program, though at reduced capacity. They really stratified the referral process at this lower capacity, so they were ensuring the patients who were most in need of these services were definitely getting them. And then the other thing that they did was apply for subsequent HPC funding in our Shift Care Challenge program, which had an entire arm focused on OUD treatment, so opioid use disorder treatment, though this was an ED and outpatient focused program. So what UMass really recognized was we need SUD and OUD treatment services for our patient population. And they really zeroed in on that being the thing that they sustained, as opposed to thinking of the telemedicine as sort of the central feature of the program. So it's a little bit of a different conceptualization. I'm here talking about how telemedicine programs sustained, and one of the ways that this program sustained doesn't involve telemedicine, but I think it's important to, understand, again, going back to that framework, like what are the core key components of the program that are generating benefit for these patients. And UMass's opinion, they zeroed in on the need for SUD and OUD treatment services. And they, acted accordingly. So I think it's important to also be a little bit flexible about what, keeping a program going looks like, and being open to reduced capacity, open to sustaining certain services and not others, or certain services but not the exact same care delivery model. So finally, the Pediatric Physicians Organization at Children's Hospital Boston, they were providing pediatric psychiatry consults in pediatric primary care offices, so using the telemedicine connection to bring the psychiatrist in. They decided that that was really the core of their program. They had a lot of buy-in because this, allowed primary care, pediatric primary care physicians who had, some ability to work with and manage patients with behavioral health conditions, but sometimes needed, a little bit more guidance about medications or about, complex diagnoses for some of these patients. And so it allowed them to bring those services in. The participants, and, this is generally the families were, and the parents or guardians, really felt like the convenience of only having to come to the pediatrician's office, which was sort of a known and more comfortable environment than sort of trekking all the way to a big hospital in the city. They really appreciated that. There was, of course, real quality and mission alignment here about we want to be providing the best care possible for the children who are in our care. And then, they really had what they needed, because this was not necessarily ongoing sessions. The capacity that the psychiatrist was able to offer them was pretty simple, and they were able to repurpose existing staff, both at the primary care offices and the Department of Psychiatry, to handle the existing, sort of administrative tasks that had to go with this program. And then PPOC is also an interesting case in terms of financial support, where they really put a lot of focus and used that administrative staff to troubleshoot submitting claims, because there were some insurers that were reimbursing some telemedicine codes that would cover the services that were being provided here. And so they, took the time during the pilot, while they had HPC funding covering the program, to test that out, find out what the policies were from these different insurers, so that afterward they were able to cover the costs of the program. They had a lot of benefit in terms of, this organization already had telemedicine technology purchased, they already had a vendor, they shared an EHR between the Children's Hospital Boston, because this is their pediatric physicians organization. And so that, I think, smoothed out some potential implementation challenges. They just didn't have those particular hurdles, which meant that they had sort of time and resources to focus on this sustainability. And so they were able to financially sustain the program. And that's, a little bit of a unique case, but hopefully you can see from all four of these examples that sustainability can look like a lot of different things, and that by applying this sort of framework and asking these questions about programs within your organization, you can kind of find options and opportunities and new understandings of sort of how to keep programs around. To wrap up, just as a review of some sort of common challenges that our programs encountered, sustaining wraparound services, so these auxiliary staff members and services that they felt like were really important and essential to the program, but are much less likely to have any prospect of reimbursement, and can be tricky to staff for because you need very particular experience. Challenges in implementation can become barriers to sustainability. So if the staffing model is not really working out during the implementation period, that's something to really keep an eye on, because it's going to be that much harder sort of as you're transitioning into sustaining the program after its initial pilot period that was agreed upon, or after its initial funding. Financial support, tried not to spend too much time on it because it is important, but it can also kind of, become sort of all-encompassing. But we just want to acknowledge it is a challenge. We will have to see what happens policy-wise in terms of where telemedicine goes from here. I think there's a lot of optimism, hopefully, that's been shared in this conference, that people are excited about this as a care modality and the potential it has, and that hopefully the payment landscape will follow that enthusiasm. But in the meantime, I know that it can be a real challenge for programs. Engaging leadership to generate buy-in, depending on your organization and sort of the norms there, the different competing goals that your leadership is always trying to balance, communicating to them clearly what the program is, what it's doing, who it's benefiting, and how, can be a challenge. So it's just something to really bear in mind. And then some lessons learned. We really want to encourage outside the box thinking, new ways of thinking about sustainability that can help you consider options you might not have previously recognized or considered. Leveraging the resources of your organization and program, sort of looking around, what do you already have that you can use and take advantage of. Again, it remains to be seen what the changing reimbursement landscapes might make possible in the future. Yeah, it's hard to know, but we sort of saw that changes can really have a big impact on how programs get sustained. Really paying attention to actively generating buy-in for the program, communicating to the other staff in your organization what you're doing and why, really engaging with any providers that might refer to your program, and then starting early with buy-in, starting early with thinking about what is this program going to look like after our initial period of running it. The sooner that you are considering all of these different avenues, I think the better off you really will be. All right. That is pretty much the end of the content I have for the presentation. But if you enjoyed this presentation and want to learn more about the work of the HPC, and in particular around telemedicine, we have a lot of really exciting upcoming publications, including a full evaluation report of this telemedicine pilot and all 4 of these initiatives, and a policy brief series discussing sort of the current landscape in Massachusetts around policy, where we've been, where we might be headed. And then we also have some current telemedicine publications, including a telebehavioral health implementation guide that was generated out of a lot of conversation with the teams of these 4 awardees who implemented these types of programs. So there's a lot of rich learning in there if you're thinking about starting a program, or even if you're in the midst of one, of doing telebehavioral health. And then our colleagues on the research and cost trends team at the HPC put together a interactive data article on the sort of increase in telemedicine use over the past couple of years. No data from this year yet, but over recent years, there's been real interest, increased uptake, and sort of looking at what that data looks like. And then, of course, if you're just generally interested in learning more about the HPC, we have some contact information, and we would, love to hear from you, have you, follow the work that we're doing. We have a lot of, as a state agency, public meetings, and they're broadcast on our YouTube channel, which can be found on our website. So a lot of really, rich, interesting stuff going on, great work being presented. So yeah, please consider staying in touch. And then I think that brings us to the questions portion.
All right. Thank you, Catherine, for the great presentation. Dave, if you could bring up the Q&A page. All right, there we go. Okay, so we have one question in the Q&A app. Let's see. So Catherine, were you surprised or particularly impressed by any of the organization's strategies for reimbursement? Oh, I'm sorry, sustainability, not reimbursement.
Yeah, I mean, I think as you saw from the run through there, all of them, I think, got, creative in terms of thinking about how to, you know, sustain the important aspects of their program. I think, you know, PPOC stands out a little bit just in terms of they kind of like found the secret sauce for making reimbursement work for the program, which is a little bit like the holy grail with these kinds of things. But then I also think, you know, UMass is kind of a fascinating case of taking what they learned and, you know, despite the fact that what we funded was a telemedicine program, they did not consider the telemedicine sort of the most important part, but that they were so laser focused on what is it that our patients need, what is it that our colleagues need, and it really was this ability to refer patients for SUD services while they were on the hospital campus, whether that was in the inpatient environment or in the ED. And so they focused in on that and found a way to even expand, you know, expand what they were doing to the ED, keep what they were doing inpatient, though at reduced capacity. So I think that that one also, you know, really stands out in terms of not being what we would have defined as sustainability at the outset of this program, because from our perspective, this is a telemedicine pilot initiative. I do also think, you know, the case with Haywood was really wonderful in that it gave them the ability, you know, nobody could have seen this coming, but there are students who are getting, you know, therapy sessions during this, you know, very difficult and stressful time for them because it was a telemedicine program. Had they, you know, instead found grant funding to bring a counselor to the schools a few days a week, you know, some sort of model where they traveled around and did the sessions in school, it wouldn't have been possible and they wouldn't have been able to transition as seamlessly when school had to go remote due to the pandemic. So that was also sort of, you know, in checking back in with them, you know, who could have predicted, but telemedicine really played a huge role for them.
All right, thank you. So I'm not seeing any questions populate the Q&A app yet, so we'll just give it a second. Oh, I'm sorry. So just a reminder, please use the EventMobi app to submit any questions that you might have. We'll just give it another minute. All right, so I don't think I'm seeing any other questions come through. So I think we could end here. Thank you again, Catherine, for your time and the great presentation. Everyone, if you could, please, when you navigate your way back to the EventMobi app, if you could scroll down to the bottom of the page that you use to access this presentation, to please fill out the feedback form. We really do appreciate your opinion. Again, thank you, Catherine, for the great presentation, and I hope everyone enjoys the rest of the conference.
Yeah, Ray, thank you to you and the National Consortium, as well as the Northeast and the Mid-Atlantic Telehealth Resource Centers. I really appreciate the opportunity to present and share what we've learned, and thanks everyone for attending.
Yeah, thank you again. It was a pleasure. All right, bye everyone.